Hello, and welcome to Advocating for Diet as First-Line Management in Eosinophilic Esophagitis. My name is Richard, and I'll be in the background answering any WebEx technical questions. If you experience technical difficulty at any time during the WebEx event, please submit your technical issue in the Q&A panel, and I will assist you. And please note, as an attendee, you're part of a larger audience today. However, due to privacy concerns, the attendee list is not displayed. All attendees will be in a listen-only mode for the duration of today's call. And as a reminder, this call is being recorded. We will be holding a Q&A session at the conclusion of today's presentation. You may ask a question at any time throughout the event by entering it into the Q&A panel at the lower right of your screen. And with that, I'd like to introduce you to your moderator for today, Kendra Valle. Kendra, you have the floor.
Hi, everyone. I'm Kendra Valle, Medical Advisor with Nutrition North America, and I hope everyone is doing well during this time. I want to thank you all for joining us today for our webinar, Advocating for Diet as First-Line Management in Eosinophilic Esophagitis, also known as EoE. I'm very excited to introduce our speakers for today's webinar, Bethany Doerfler and Sally Schwartz. Bethany Doerfler is a registered dietitian with more than 22 years of experience working with patients with digestive health conditions. She currently practices in the Division of Gastroenterology and Hepatology at Northwestern Medicine in Chicago, Illinois, and services as adjunct faculty at Marciella School of Nursing, Loyola University College, Chicago. Her clinic and research focuses on providing wellness-based medical nutrition therapy for digestive disorders and allergic bowel diseases. Sally Schwartz has been a registered dietitian for 22 years, working at Lurie Children's for the last 17 years with the Department of Gastroenterology, Hepatology, and Nutrition. Her areas of special interest include eosinophilic disorders, inflammatory bowel diseases, and neurointestinal and motility disorders. Sally has presented numerous lectures to the medical and lay community on topics including eosinophilic esophagitis and has been involved in groundbreaking research in nutritional therapy and eosinophilic esophagitis. So before I pass things over to Beth and Sally to start today's presentation, I have just a few quick housekeeping messages. At the close of the webinar, we will be hosting a Q&A session. We did receive some questions prior to the webinar, which will be addressed. However, if you have any questions during the presentation, please type them into the Q&A box on the right side of your screen. Also, a copy of the presentation is currently available at nutritionlearningcenter.com, and a recording of today's webinar will be available for download on the Nutrition Learning Center within 2 weeks following today's event. And with that, I am going to pass it off to Bethany to begin today's webinar.
Wonderful. Thank you, everyone. We're so glad to be here, and thank you for taking time out of your day to join us. This is just a treat for me. I've had the pleasure of working with Sally for almost 15 years. She really started a lot of what we do in our practice on the adult side and helped train me. So I tip my hat to my colleague here and tell you that she is one of the originals. Here are our disclosures. So to walk through our objectives today, because Sally really focuses on the pediatric experience and I really focus on adults, our goal was really to give you this whole lifespan approach. What do we do? How do we approach kids and families with eosinophilic disease? And then how do we help them transition into adulthood care, or perhaps we're catching them as an adult new diagnosis? We're going to update you on the current guidelines, the updated guidelines on management of eosinophilic gastrointestinal diseases, and also spend quite a bit of time talking about how you can use elemental formulas as a supplement or as primary care, and we'll identify some strategies to really add to your toolbox of being a successful clinician working with these patients using diet management. So the goals of diet management in eosinophilic disease, and certainly for EoE especially, really is to improve disease activity. And we'll talk to you about efficacy rates. We know that the sooner that we can diagnose and intervene, the more likely we are to minimize risks, especially things like strictures. Of course, for dietitians, a major priority is improving or maintaining nutritional status, and we'll share some tidbits with you throughout about our patient experiences there. And then we're also interested, of course, in the role that diet manipulation can have on quality of life. We hope that improving someone's symptoms, improving their disease management, improves quality of life, and we'll share some data with you on that. So let's take a walk back into kind of where this all got started. Sally will share a few more details with you in some slides to come, but the backbone really of dietary management of EOE revolves around the 6-food elimination diet, which you see visually depicted here. Amir Kagawala, one of the pediatric gastroenterologists at Lurie Children's, really started off this idea that if we got rid of the biggest offenders, kind of the most likely culprits, could we improve disease management and symptoms in EOE? And what you see here are the big 8, so to speak, or 6 food groups, things like eggs and fish and shellfish, soy, wheat, dairy products, nuts, and tree nuts were those causative agents that have been studied really over the last 15 years or more. Every center does diet therapy a little bit differently. The way that we typically schedule it or set it up at Northwestern on the adult side, we have a tendency to go a little bit faster than they do on the pediatric side. What you can see, of course, is that we get started when someone starts on diet management, we try to remove those causative agents, and we do that for roughly 6 weeks. After 6 weeks, we follow up with an endoscopy to see if the esophagus looks good, if they've met that criteria of having less than 15 eosinophils per high power field. If the esophagus looks good, we consider them a success, and we try to start reintroducing food. If the esophagus doesn't look good, then we go back to the drawing board and consider, was there contamination? Did we miss an allergen? Or do we want to escalate medical therapy? We start with the least likely subjects, and we typically add in things like fish and nuts for roughly 2 weeks apiece. So after about 4 to 6 weeks, we'll repeat the endoscopy and kind of move on. When we get into some of the higher allergen foods like wheat and dairy, we do those as single food trials because of the fact that these are so highly allergenic. We don't want to kind of mix them together and skew our interpretation results. What you may have seen also from the last slide, and what I'd like to discuss on this slide, is that when we're embarking on an elimination diet and a subsequent reintroduction, it's a lot of endoscopies and it can be a lot of time. Under best case scenarios, removing those foods and doing serial reintroduction can take at least 6 months. So our colleagues in Spain suggested that if we could kind of lighten the load and eliminate the top 2 big allergens, that would cover many patients and may be able to improve quality of life by reducing the number of endoscopies. Sally will show you some data in just a bit to say that while this approach may be helpful to start with 2 food and kind of work your way up, the efficacy rate is not quite as good. And so it really needs to be an individualized approach, whether you start with 2 food elimination or a larger group of food elimination. Because ultimately at this point, we don't know if starting with a larger elimination group or a smaller elimination group translates to improve health-related quality of life in our patients.
I'm going to expand on what Beth was discussing in regards to the efficacy of the various diets used to manage EOE. The group from Spain, led by Lucendo, published a meta-analysis on the different EOE diets. This table shows the histologic remission rates broken down by age group and shown by different modalities of dietary management, including elemental diet, 6-food elimination diet, and other empiric elimination diets, 2 food, single food, 4 food, and allergy testing guided elimination diets for EOE. I would like to direct your attention to the bar graph on the left for pediatrics, as Beth reviewed a little bit the adult results. As you can see, elemental diet has 90% efficacy in children and similar results in adults, which confirms that elemental diet management for EOE is superior in terms of remission, histological remission. The next diets include empiric elimination diets from 6 food down to 1 and show that they are less efficacious. Specifically, the 6-food elimination diet had 72% efficacy in children. The 4-food elimination diet shows 64% efficacy, which had some indirect data from prospective studies on the 4-food. The 2-food elimination diet showed 43% efficacy, and a single food or milk elimination diet efficacy ranged between 35 and 56. Of note, the allergy-directed elimination diet also had a meta-analysis that showed about 46% efficacy. Prospective studies are warranted regarding the efficacy of diets. What we know is more restrictive diets show higher efficacy in histological remission, but other factors, including patient acceptance and adherence, play a part in the discussion, as Beth had discussed, of which diet management route is individually decided upon between the patient, family, and team. One of the first factors to determine the type of management is, of course, the patient nutritional status. Now, the nutritional status, oops, wrong button. There we go. Nutritional status is the RD's bread and butter. So I'm not going to spend too much time on this slide, but I do want to highlight a few areas that we key in on in our assessing our EOE patients. First of all, growth. And we'll look at growth a little bit more closely because it is so important with our patients and children with EOE. Regarding COVID-19 and how it has changed the way we see our patients, many of us are not able to do a hands-on exam virtually or even have current anthropometrics. Boston Children's Hospital has a wonderful handout on instructing families on how to weigh and measure your child at home, and it can be found on their website. We do want to address feeding history in our patients to assess for a pediatric feeding disorder, and I will be discussing this in more detail as well. Psychosocial history, we do want to assess family dynamics, multiple households, multiple caregivers, lifestyle and activities, and feeding insecurity, especially now during COVID-19, to screen for feeding insecurity and make referrals to social work as needed. Finally, we need to assess the readiness for diet management in households. For both parents and patients, they need to be motivated. COVID-19 may add extra anxiety, and families may feel diet management is too stressful. On the other hand, families may feel now is the best time when everyone is home, there's no rushing around to appointments in schools and activities, and there's more home cooking and the ability to make these diet changes.
More at the role of doing nutrition assessment in adults. You know, of course, we're not quite as concerned on the pediatric side with growth parameters as we are with adults. And actually, many of our patients will try to use this time and they will tell us, you know, I've really been looking at changing my diet. I'd like to try to make a healthier eating pattern for myself and for my family. And so based off of these, the adult assessment guidelines with the Academy of Nutrition and Dietetics and Aspen, you can still use your nutrition-focused clinical exam in adults. Although one thing that I would mention is that we don't think of EOE as a systemically inflammatory process. So you wouldn't have the same kind of cachectic concerns that you would with a cancer patient or someone with, say, inflammatory bowel disease. And part of your diet history, besides looking at kind of obvious sources of malnutrition, is really to kind of assess their dietary patterns and see where you would really want to kind of make those important allergy-free substitutions and how you can keep diet quality, calories and protein maintained while you are removing and reducing some of the potential allergens from their diet.
Okay, let's talk about growth in pediatrics. Currently, there is limited research on growth needs of children with EOE. Current studies, though, that are available reveal more than 15% of children with EOE were malnourished at diagnosis. Getting accurate anthropometrics are imperative to ensuring our children are meeting their nutritional needs for optimal growth and development. There's a couple studies I did want to mention. Jensen et al. Completed a retrospective review of a large number of EOE patients for 12 months, starting at diagnosis, and looked at 6 different management modalities, including topical steroids, elemental diet, diet elimination, topical steroids and supplemental elemental formula, diet elimination with topical steroids, and diet elimination with supplemental elemental formula. During this 12-month trial, they found no significant difference in height Z-scores between management approaches, with the exception of the elemental steroid group. Meyer in England followed children with GI allergic disorders, including EOE, cow milk protein allergy, and FPIES for 4 weeks on the elimination diet. They noted that with the dietary advice of a registered dietitian, which included recommendations for hypoallergenic formulas and vitamin and mineral supplementation, weight was shown to improve. When we look at our allergy colleagues and what they have reported on in regards to growth, we know that allergy to cow's milk is a risk factor for poor growth, and the presence of 2 or more food allergies has been associated with reduced height for age compared with controls. In addition, Christie reported more than 25% of children who had more than one food allergy consumed less than 67% of the RDAs for calcium, vitamin D, and vitamin E. Food avoidance and EOE, whether it's due to prescribed elimination diets and or feeding disorders, can lead to significant impact on macronutrient and micronutrient levels, and we must monitor these patients closely to ensure nutrition needs are being met. Next, I want to talk a little bit about picky eating and pediatric feeding disorders and their correlation in EOE. When we talk about picky eating, it's a relatively common problem that we find during childhood. Children limiting amounts of foods, restricted intake of certain foods, only eating certain color vegetables or avoiding vegetables, unwillingness to try new foods. The good news is most of the time these picky eating behaviors are outgrown. But when are feeding issues considered feeding dysfunction? And is there a connection with EOE? It has been reported in the literature that feeding disorders can occur in up to 59% of children with EOE. In the last several years, we have come a long way in regards to categorizing these patients so they are able to get the appropriate care involving multidisciplinary collaboration. Pediatric feeding disorder, or PFD, is a proposed definition by Godet et al., which provides a more unifying diagnostic term. It's using framework of the WHO International Classification of Functioning Disability and Health, and the pediatric feeding disorder refers to impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. Avoidant restrictive food intake disorder, or ARFIDs, is a newly defined eating disorder in the Diagnostic Statistical Manual of Mental Disorders, that's a mouthful, the 5th edition that was published in 2013. ARFID is defined as an eating disturbance manifested by persistent failure to meet appropriate nutritional and or energy needs. However, ARFID incorporates nutritional complications and acknowledges that feeding disorders are common in certain medical conditions. However, it requires that the severity of the eating disturbance exceeds that associated with the condition and specifically excludes children whose primary challenge is a skill deficit. The progress the medical community has made in terms of identifying and classifying these patients is so important to ensure best practices and getting our patients the multidisciplinary management that is needed. So how do we identify these patients? On the right side of the screen, you'll see some behaviors to screen for when you're doing your nutritional assessment and getting a detailed feeding history. You want to ask questions about food texture, volume, and variety. Many children will reduce the volume or variety of foods that they eat, and EOE patients are known to avoid higher texture and solids, preferring soft, safe foods or liquids. Also asking about the duration of mealtime, their process of eating, if they drink a lot of liquids between each bite. This can help identify our patients who have disordered feeding patterns. The key is to refer to a feeding team for evaluation as soon as a problem is identified. A feeding team should include a pediatric feeding therapist, occupational therapist, speech-language pathologist, developmental psychologist, registered dietitian, and gastroenterologist. Again, keep in mind that once the GI disorder has been medically managed, the feeding disorder frequently does persist. This next slide is a really nice model from Dr. Robeson and the group from Utah, and they developed this model to show the development of ARFIDs in children with EOE that have been prescribed elimination diet. As you can see, there are several known risk factors for the development of overrestricted intake, or ARFIDs. Some of these factors include, which are the bubbles that surround ARFID, sensory or temperament-based food avoidance, which may be due to the elimination diets leading to complaints of lack of diet diversity or reducing the joy of eating. Anxiety-based food avoidance may be a concern that the intake will trigger an EOE flare or disrupt the prescribed diet plan. Fear-based food avoidance includes distress that intake of that food will lead to impaction, food impaction, or other EOE symptoms such as vomiting and or pain. A cycle of starvation it can be due to low calorie intake on the elimination diet, which leads to a cycle of low energy, psychomotor, and cognitive slowing, and further poor intake. It is important to consider and monitor for ARFIDs and feeding disorders in patients on elimination diets, and discuss options of less restricted elimination diets or medical therapy if able. Close follow-up for patients on diet management should include monitoring nutritional status and quality of life after disease remission, including patients who changed to medical therapy.
And so if we shift gears now to kind of look at the updated guidelines, in a joint collaboration with the AGA, the American Gastroenterology Association, and the Allergy Immunology Practice Group, there was a joint collaboration to update clinical guidelines for the management of EOE. Our own Northwestern's own Dr. Ferrano, Dr. Gonzalez, and some others collaborated on this. And while this piece also includes important management strategies for medical therapy, et cetera, there is a section on diet because, as you know, diet is really considered one of the backbone treatment options for people with EOE, or management options. And so 3 real large questions emerge which we would like to address. Should the elemental diet be used in the management of eosinophilic esophagitis? Should empiric food elimination be used with patients with EOE? And what about allergy-based testing, or kind of test-directed diets in EOE? And so to answer those and kind of set the stage for the next few slides that Sally and I would like to discuss with you, we want to talk to you about how to do an elemental diet properly. You know, if you go back 15 years, when we really first saw the role of food allergy, some centers were really using exclusive elemental diets to treat EOE. We've gotten away from that a little to do the empiric elimination, which incidentally we do know is more effective in adults and even in kids versus test-directed. So we advocate for an empiric elimination diet. And we try to reserve elemental diet for use for people who have refractory EOE, who are very motivated to do diet, or will use elemental formulas as a supplement to a restricted diet, particularly in patients who have like an IgE overlap, because when you start looking at food labels among formulas on the grocery store, you know, you become very skeptical of the safety and the level of cross-contamination risk among some of those products. So now we transition to talking about the elemental diet. What Sally and I would like to do is kind of walk you through some particular strategies on how to do this, how to clinically manage your patients who are using this as a primary management strategy.
Okay. I would be remiss not to include the origins of the elemental diet in the management of EOE. In 1995, Dr. Kelly and colleagues at Johns Hopkins University reported the first study to use amino acid-based formula, or elemental formula, or elemental diet. 10 children who had been diagnosed with GERD and were unresponsive to PPI therapy used elemental formulas for 6 weeks, followed by reintroduction of foods. This was the landmark study that discovered the ingestion of foods causing EOE. And when we talk about the elemental diet, we're talking about 100% free amino acid-based formulas. There are several available on the market. They're infant and child, over age 1 appropriate. They're unflavored, there's flavored, ready to feed, semi-solid. It's key to note that hydrolyzed formulas are not appropriate for this diagnosis. The formula is used to provide 100% of estimated nutritional needs, and often we allow foods, a single food, for oral stimulation. It's important when you follow up or when you're planning with your patients to calculate all macro and micronutrient needs, including water, and compare to how much formula the patient is actually getting on a daily basis. You may have recommended 2,000 calories for your patient, but they're only able to drink 1,500. Some of the ins and outs of the elemental diet, again, during that remission stage, which is the first, when we take all the foods out, the amino acid-based formula is the sole source of nutrition. And again, we allow for a low allergenicity food for oral stimulation. There's rapid improvement, as we know, due to the efficacy slides that we had reviewed earlier, and as soon as 4 weeks to a clean endoscopy. Generally, though, most centers do an 8 to 12-week trial. It's important to keep in mind that elemental diet is not just for that first initial 8 to 12 weeks. It extends as a primary source of nutrition through the food reintroduction stage, which will vary per patient and per center, but is generally at least 9 months. And when we talk about food reintroduction, again, it varies center to center. In my experience at Lurie Children's, we have worked off the model that was developed originally from the group at the Children's Hospital of Philadelphia, or CHOP, which starts with low allergenicity food. I've included this roadmap in one of the next slides. Due to time, I wanted to put this slide in for your review, but we know a lot of the challenges of the elemental diet. So I want to make sure we have enough time for the Q&A at the end. So I'm just going to leave this in our slide deck and move on to strategies, because this is what we want. We want how to take care of these patients. Our tips for serving amino acid-based formulas, again, serve in a chilled or covered sports or straw bottle. Again, smell is such a big part of taste. And if your patient can smell the formula, they all don't smell that well. The taste has improved, but there is a medicinal smell to it. So covering it, putting it in a sports bottle, maybe with a wide caliber straw, can help with ingestion and serving it chilled. Again, trialing flavors of the amino acid-based formulas. There's some flavoring ideas in the box on the upper right part of the slide. And I've gotten a lot of these ideas from our patients who are in the trenches trialing these formulas. Again, when I give samples to families, I give them all the different flavors. You never know, even though they think they may just like the strawberry, or another flavor, you can mix them together. So you always want to give them all the different flavors. Tips for foods, again, to provide a list of the allowed foods, be it small in the beginning, provide them ideas on how to prepare these foods. And at mealtime, we want to structure our meal times. It's so important in children, averse behaviors don't start or we don't make them worse. We want to have structured meals, meal times, and locations for the foods and formula. You want to start with familiar food prep and try different forms. Apples can be made a bunch of different ways besides slices and cubed, cut up with cookie cutters, applesauce, baked or stewed apples. You can also shred apples. So there's many different ways to get creative with our single food trials. Here's this roadmap I had mentioned a few minutes ago in regards to the food reintroduction. Again, it's a slow reintroduction based on allergenicity, starting at the left hand of the slide where it says start your lower allergenicity foods. Generally, anywhere between 3 and 6 foods may be introduced per trial. We tend to do 3 to 4 at Lurie Children's. And then you slowly move towards the right to higher allergenicity foods. And scopes or endoscopies will need to be done after each food trial. Some free foods may be added to help with the foods for food reintroduction, and the ingredients are in that right freebie trial, including things like sugar and baking powder, baking soda, and also the oils that are found in the formulas that they're drinking. So now we're moving on to the elimination diet. When we talk about elimination diet, it could be any one of the elimination diets, whether it's a single food elimination diet or 6 food elimination diet. So this will give us some strategies on moving forward. Quickly, the ins and outs. Again, the remission stage is anywhere from 8 to 12 weeks when we're taking all the foods out. The reintroduction stage includes adding foods back in one at a time that were removed. And we're monitoring for symptoms with repeat endoscopies. Of course, there is a high risk of nutritional deficiencies, which I'll touch on in the next slide, and malnutrition with any of the elimination diets. So we need to assess for that. And education. We'll bring this up a little bit down the road when we're talking about our toolbox, but we need to always assess and our patients when we're following up with them initially and ongoing. So this is a big slide, and I could probably spend the full hour on this. So I will touch on it very briefly, but I like to highlight a single elimination just to show the impact of what removing one food is. If we look at the bottom of the slide, it shows what nutrients are at highest risk for deficiency that we need to replace. for a dairy elimination diet. So the protein can be replaced by soy, eggs, meat, poultry, fish, nuts, legumes, and to a lesser extent, grains and cereals. That is, of course, if the child doesn't have any other diet restrictions or IgE-mediated allergies. Calcium and vitamin D can be replaced with fortified foods, such as calcium and vitamin D, fortified orange juice, breakfast cereals, and plant-based milk beverages. Other nutrients to consider at risk is iodine, which can be reduced in a dairy-free diet, but may be fortified in some plant-based milk beverages, and vitamin B12 may be at risk in our vegetarian patients. Again, looking for soy-based milks that are fortified is key. As we increase the number of foods we are eliminating, we are also increasing the number of nutrients at risk in our patients on these diets. So careful attention must be paid to ensure adequate nutrition in any of our elimination diets. So managing our nutrition adequacy, again, it has to be individualized because you'll have patients that will come to you on a milk-free elimination. The last few patients I've had, I thought, oh, it's a milk-free elimination. And I open up the chart and, they've got 10 other allergens that they're allergic to. So you have to be able to address how to remove the foods and appropriately find substitutes for them. We want to focus on nutrient-rich whole foods and guidance based on a balanced diet. Always go back to the balanced diet because I think when we take things away, we want to make sure that they can see how it will fit and how it will be healthy. Amino acid-based formula should be considered for supplementation in children younger than 2, if patients are malnourished, or if patients have a limited intake. Honestly, I give formula samples either in person or now I order them virtually if I have a telemed appointment to all my patients because you'll be surprised at what patients will want to drink them. A lot of my teenagers who are active in sports want to make sure they maintain their energy levels, of course, and they will mix their elemental formulas and make a homemade smoothie with allowed ingredients. So it's always a nice tool to have for their toolbox. And of course, vitamin and mineral supplementation may be needed as well, including B vitamins, calcium, vitamin D, fiber, zinc, iron, and selenium. This slide just highlights the importance of teaming that elimination diet with the elemental formula. It can help solve some of these dietary problems that we see with elimination diets. It helps reduce the risk of deficiencies. It can offer more options in the diet and improve or enhance quality of life by ensuring there's additional calories, adequate calories. It's less volume needed than your strict elemental diet, and it can help meet psychosocial needs as well. So again, I think, I keep saying it over and over, but you want to focus on safe foods, and you want to make sure that we're focusing on what can be eaten versus what we're taking away. I like positive reinforcement. I think it's always helpful. And again, I love using Choose My Plate. I was so happy when they came out with this because it just shows them how the healthy, wholesome meal for adequate nutrition can fit on their plate. We want to make sure that we're providing good examples for them and nutritionally appropriate alternatives.
And to piggyback off of what Sally was saying, we share a lot of our educational materials together and kind of work on some of this together. And one thing that we found to be really helpful is that in addition to the list of patients often want to know, well, what do I look out for? How do I know an allergen is in there? And that's really essential for dietitians to go through proper label reading. But the flip side of that is also really emphasizing these are the things that I really want you to be eating in the course of the day, and providing shopping guides and snack ideas. And with the adults especially, I've kind of shifted this a little bit also to fit in within like a cardiovascular healthy diet, because when people embark on this, their goal is like, okay, I would like to lose weight. I would like to get healthier. I'd like to lower my cholesterol. So some of the things that, rather than focusing on just gluten-free and dairy-free, I also really like to make sure people are getting enough antioxidants, heart-healthy fats, homemade foods. As Sally said, COVID is a great time for us to be transitioning to a bigger focus at home. So these are kind of a positive checklist that I often give to people along with some of the other educational materials that we give. It's important for us when we're looking for milk alternatives, when you have a patient with high calorie needs, like a young adult male or perhaps one of your pediatric patients, this discussion of milk substitutes becomes very important to consider. If I have an adult that I'm not so worried, they're maybe trying for intentional weight loss, then for them to do a low-calorie oat or coconut or perhaps almond milk, depending on their level of diet restriction, makes sense. Sometimes those can be 30 to 50 calories per serving. But if you have someone with high calorie and growth needs, to switch from, say, 2% cow's milk that offers 120 calories and 8 grams of protein, if you can't make that up in one of the plant-based milks that you're using, then again, you're going to have to get savvy with replacing that in other ways. Another trend that we've seen is that some of these vegan or plant-based milks are also shying away from complete fortification. And so that's something to make sure that you are considering as you're kind of crafting some of your nutritional recommendations for people. And then finally, rice milk should not be given as a primary beverage to kids under the age of 4 years because of the arsenic content. When we look at protein, this may not be new material to you. In kids, of course, you're really making sure that they're getting enough. In some of our adults who perhaps had a difficult time eating animal proteins because of a narrow caliber esophagus, we really have to, or perhaps some of our vegetarian clients, we really kind of get into the nitty-gritty of, well, you'll get 8 to 10 grams here and another 5 or 6 here, so that you really can meet that minimum protein requirement. I often like to provide a list of safe and healthy snacks split up by sweet and savory that includes not only some homemade snacks for people, but also some brand names. Snack Safely is going to be a website that we're going to show you in our resource page in a few minutes, and they have a great allergy-free snack handout that you can also use to augment your practice.
When we consider supplements, you should definitely consider a daily complete multivitamin, especially in patients that may eat the same foods every day or have very little variety in their diet. Also to consider a multivitamin in patients that have more than 2 food groups eliminated. And of course, if there's a micronutrient deficiency suspected. Additional supplements as indicated by diet, calcium, vitamin D, and iron. And we do need to be mindful of additional medication use and their interactions. For our patients that are on protein pump inhibitors, which many often are, and if they need a calcium supplement, choose the calcium citrate versus the calcium carbonate supplement, because calcium citrate does not need that gastric acid that has been reduced by PPI, so it is better absorbed than the calcium carbonate is. When we're talking about nutritional monitoring in our elimination diets, again, we want to do our physical assessment. We want to monitor for growth. And if we're able to do a nutritional focused physical exam, we want to assess their dietary intake at a minimum, a 24-hour recall of what our patients have been eating, and biochemical monitoring, especially if nutrition deficiencies are suspected, and following up on them individually. Our checklist for education, I wanted to put together a little checklist for everyone. I'm sure most people have their own, but this kind of makes sure you run through the list of everything that you've done with your patients. I always feel like, am I missing something? So you want to make sure that you're, again, individualizing it to each patient and their families, and provide appropriate substitute. Like Beth said, we like to give lists of what they can have, ideas of what they should eat or what they can eat, and give them suggestions, and of course, meal planning and recipes. Obviously, correct any micronutrient deficiencies, realistic diet plan, and again, our resource identification, including websites. The formula companies have great information, as well as the specialty food companies and support groups. And on this next slide is a wonderful slide that shows you lots of the resources. The ones on the bottom are actually published articles that have education material in them as well. So please look up these if you need some more resources. There are a lot of excellent resources out there right now.
And so looking a little deeper at those toolbox strategies, we know that shopping can be an issue. And so again, making sure that the educational materials are customized to patients. You know, a couple of things that maybe would be on hold that I would just mention about dining out and travel. I think that patients really benefit from using chef cards to kind of give to the back of the house about some of their food limitations, calling ahead of time to kind of talk about some of the things that they need to be limiting. And then for work, you know, I have a lot of adult clients that are gone for 24 to 48 hours and will say, boy, you know, what can I eat in an airport? I can't really guarantee that anything that they can get there is safe. So oftentimes I'll try to supplement more heavily with some of the elemental formulas until they kind of get back to their baseline, whether it's home or a restaurant that they know, and then we kind of return back to their typical diet. Of course, we always go through what are the areas of cross-contamination. You know, in adults, of course, people want to know what about alcohol and coffee? So we spend quite a bit of time talking about alcohol. And certainly happy to answer any of those questions in the Q&A a little bit further. But, you know, things like communion, shared cooktop surfaces, fry oil, these can all be substantial areas of cross-contamination that we really want to alert our patients to be on the lookout for. Interestingly, one of the questions we often get is our patients will say, what happens if I have a little bit, or if I accidentally mess up and I, you know, ate my daughter's mac and cheese? Well, the way that we answer that until we have more definitive data on that is that, you know, we don't know, like we do with celiac disease, whether or not a small amount, you know, we think a small amount is really enough to kind of activate your immune system. So we really treat you like you are very highly allergic, almost anaphylactic. But until we have some non-invasive ways to kind of look for those eosinophils besides an endoscopy and biopsy, we can't really determine those threshold levels like we can with, say, celiac. In our celiac population, there's some research suggesting that perhaps stand-up toasters or shared cooktop surfaces maybe don't transfer as much, at least gluten protein. We would never want to run the risk of that with someone with an IgE allergy. And we really don't know this in EoE, but I would say stay tuned that there may be some more research coming down the pipeline on this. Interestingly, COVID, of course, has changed everything. And one of the biggest fallouts that we are seeing now with label reading is the FDA is allowing food manufacturers to make substitutions based on ingredients because of what they may have access to, and also that they don't have to disclose this on their food label. All of the patient advocacy groups dealing with EoE, with FPIEs, with food allergies, sent a letter of warning to the FDA urging them to at least require manufacturers to notify consumers if this change has been made. So what I would tell you as a clinician is at this point, outside of perhaps foods made in dedicated facilities, that large brands or even small brands do not have to let you know if a food substitution has been made. And the really only safe way to know if an unsafe ingredient has been substituted is to reach out directly to their customer service to find out. In our group at Northwestern, we also looked at some of our patients who had used diet management in the past, elimination diets, and we followed them forward and asked them, you know, how did adherence with the diet go? What were your quality of life concerns? And we have kind of two slides to share some insights. And what you see is the kind of the blue wave there are people who are actively still following the diet. And the red wave there are people who did do the diet but have chosen to drop diet management and, you know, have chosen the medical management route. And we looked at this with quality of life, and you see some of the questions on the bottom that, you know, we asked some questions about, was it difficult because the diet was restrictive? You know, how was it in social settings? If we look at the next slide, you'll actually see some numbers, some data that we had almost 50 people and people who were actively still using diet intervention to kind of maintain their disease remission, had said about 66% of people said, you know, socializing is difficult. One of the biggest things that jumped out was the anxiety over kind of the diet, whether or not they were doing it right. And that was a bigger deal for people who had multiple food allergies. And so what we may find is that people who have one or two antigens identified may be people that have kind of an easier time kind of staying adherent to the diet, and that as you get up beyond 1 and 2 food antigens, that diet therapy or diet maintenance may be a little bit more difficult for our patients and may more negatively impact their quality of life.
There we go. Sorry about that. So this is this algorithm is from the American Academy of Allergy, Asthma, and Immunology's work group, or Quad AI. They authored a wonderful resource that's included on our resource page called the Nutritional Management of Elimination Diets. And this shows referral to a registered dietitian if there's ever any question that RDs are imperative for the treatment in children and adults with EOE, here is your answer. It's with a resounding, yes, we are. So I think we have time for our case studies, which is great. So I'll go first. I have a pediatric patient, a 2-year-old, that presented with poor weight gain, diarrhea, and abdominal distension. He had the $1 million workup, and he was shown to have a celiac panel was flagged for celiac disease. So the physician went ahead and did an endoscopy, which he found villous atrophy in the small intestine, as well as eosinophils, 75 to 90 per high power field. So the plan was a gluten-free diet education for our newly diagnosed celiac patient, and he was started on a PPI 2 times a day for 3 months. The next endoscopy, which was 3 months later, showed that the villi normalized in the small intestine, but the esophagus got worse. The EOs were 275 to 300. Symptoms reported at the endoscopy included anorexia, aversion to solids, and the plan was started to start this child on a 6-food elimination diet in addition to gluten-free diet for his celiac disease, and provided samples of amino acid-based formulas. During a follow-up visit 1 month later, there was poor compliance with the 6-food and poor caloric intake. The child was not accepting drinking the amino acid-based formula by mouth, so a plan for a G-tube was placed and the amino acid-based formula or elemental diet was started. This is a growth chart on the right where you can see at the beginning, before you see that arrow where the G-tube was placed, that he was struggling to get on the curve for his weight for age. And the amino acid-based formula provided 100% of his needs, and he was allowed apples for his oral stimulation. When the endoscopy was repeated, he had treated EOE with 5 EOs per high power field, and so we started the plan for food reintroduction with low allergenicity using that roadmap that I had showed you earlier. Of fruits and vegetables, and continued the elemental diet. He did have pretty significant feeding disorder, so he was referred to a feeding team, including a psychologist. His amino acid-based formula was providing at least 70% of his calories for several years, and even though his histology has improved, his symptoms of feeding dysfunction have remained. He was seen earlier this year, and he's been off the elimination diet now for 2.5 years. So he was on some form of diet therapy for over 8 years. He right now is gluten-free for his celiac disease, and he does have IgE-mediated allergies to peanut and tree nuts, so he's also off those. He was found to have 2 causative foods, milk and egg, but since he is on solid steroids, he enjoys those foods in his diet, as one of his favorite foods is gluten-free pizza. And he remains on some tube feedings. He gets a breakfast bolus every morning of about 500 calories, and his goal is to be off his tube for high school. And he's continuing to work with his psychologist on his ARFID.
So looking at another case was a young gentleman who sought treatment early on as a pediatric patient and then transitioned to adult care at Northwestern. He has a history of IgE, allergies to fish, first identified when he was young. Developed some food avoidance and vomiting that kind of sought him to go through that GI evaluation and subsequently be diagnosed with EOE. He was started on a 6-food elimination diet and was supplemented with amino acid formula. As he grew through his teen years and kind of intermittently used both dietary management and medical management, there was some concern in his early teen years over avoidant behaviors, and he was pretty much exclusively managed with medical therapy in his teen years. When he first came to me, he had a restricted but full solid diet. He was eating lots of animal protein, pork, poultry, eggs, beef, some fruit, and these are some of the grains and so forth that he was eating. So to Sally's point that she brought up earlier, although he had a few foods that were known triggers, milk and finfish, you can see that there are a lot of foods that just never made it into his diet. I don't know about things like seeds or coconut or some of the other grains like sorghum and millet, et cetera, because those were not foods that he typically ate. And one of the things that his mom said in our session was, boy, I'd really like to round out his diet nutritionally. Of course, I'm always thinking about what new allergens I might potentially be adding into someone's diet as I look to expand it further. So we utilized, one of the things that we decided to do is that we wanted to supplement him with amino acid formula, in part because we wanted to, they were paying out of pocket, and because of his diagnosis, we said insurance can pick this up, and we'd like to kind of supplement your nutrition, especially from a vitamin perspective. He had an accidental contamination episode, which kind of flared his esophageal symptoms. That triggered kind of an anxiety response, and he kind of quickly stopped eating orally and kind of self-restricted to just liquid diet and just amino acid formula. So we kind of worked and collaborated with our team to create kind of an exposure therapy hierarchy of kind of getting him back into eating some of the foods that he was eating before. And we also plan to expand to some of these other foods that maybe weren't part of his diet, like seeds and other grains and other gums and so forth, to see that, to kind of show him that we can kind of have good outcomes even if we're adding some of these allergy-free foods in. So in summary, in light of these two case studies and kind of the information that we discussed today, one of the things that I want to highlight for the clinicians that are joining us today is that elimination diets are a very effective management tool. And when you are doing them properly with a team of specialists, the gastroenterologist, the allergist, the dietitian, perhaps other players like a feeding therapist and a psychologist, this really gives kind of optimal therapy and optimal management for people. Dietitians often have the dual role of assessing patients nutritionally, but also helping to execute the elimination diet. Assessing for eating behaviors, as we saw in our young adult patient, is now kind of a critical component that we really need to be looking at as part of our nutrition assessment techniques. Individualization is key, and we need to also focus on the fact that really healthy diet and promoting what foods people can eat really optimize the experience for our patients who are choosing food elimination as a management strategy. So with that, thank you, and I'd like to turn it back over to our session moderator to be able to give you important details and also open it up to questions.
Thank you so much, Bethany and Sally. That was very informative and very helpful. So we are going to get started with the Q&A session shortly. If you have any questions, please go ahead and type them in the Q&A box on the right side of your screen. And to receive CE credit for today's webinar, please complete the survey that you can currently see displayed on the screen. And there are a few ways to access the survey. So you can take note of this URL. You can click in the hyperlink in the chat box. You can wait for the survey to pop up immediately following the conclusion of today's event. Or you can open the camera on your smartphone and hold the camera over the QR code, which will grant you direct access to the survey. We really appreciate you completing the survey and truly value your feedback, as this helps us continually improve our educational offerings. Once you complete the survey, you will obtain the webinar code, which you can then enter into your NLC dashboard at nutritionlearningcenter.com. And upon entering the webinar code, you will be able to view and download your certificate on your NLC dashboard. So let's go ahead and get started with the Q&A session. And this was actually a question that we received prior to today's presentation. It is not necessarily related to EOE, but another EGID. So this individual read an abstract at a recent meeting that Dr. Gonzalez at Northwestern University stated during her virtual presentation in terms of suggesting that food antigens play a dominant role in the eosinophilic gastroenteritis pathogenesis. This individual said, typically, we have not modified patients' diets for eosinophilic gastroenteritis can you address and advise? And Beth, I'll direct that question to you because I know you work very closely with Dr. Gonzalez.
Yeah, it's a great question. So we're very excited. Dr. Gonzalez and is part of the team of eosinophilic researchers, the Seegers Consortium, along with specialists at Cincinnati, Colorado, and all over the country, in conjunction with some funding from the NIH. The goal was to get data on a kind of common clinical practice, which is to use elemental formulas as a dietary management strategy for people with eosinophilic gastroenteritis or enteritis. And because there are some good medical therapy options, but we know less to this point that about what role diet plays in not only pathogenesis, but also management of other EGID, EG, and EGE. And what I can tell you, there'll be some future publications coming out on this, but the abstract was able to demonstrate that we were able to meet our primary treatment goal, which is having optimal histologic improvement in the sample, as well as symptom improvement. And these were patients that did exclusive elemental diet for 6 weeks. We are ultimately hoping to be able to kind of study what foods they tolerate when they are reintroduced, to be able to kind of provide a framework, much like we do in EOE, for what some of the most likely triggers are.
Great, thank you so much for sharing. It'll be exciting to see that published data. We had a question come in for Sally. Sally, would you be able to repeat the information on calcium carbonate versus calcium calcium carbonate again, and which one to use? I think it was referring to the two different types of sources of calcium.
Sure. When we talk about our patients, a lot of our EOE patients are also on medications, like a protein pump inhibitor. And the job of that, again, I'm not a pharmacist or disclaimer or physician, but we know that the protein pump inhibitor helps reduce the acid, and acid is needed to absorb some of these salts. Calcium carbonate is one of those salts that needs the acid to help absorb it. So if a child or an adult is on a PPI and taking Tums, it's not going to be absorbed as well as, say, a calcium citrate, which is a different salt, which doesn't need that acid to absorb it. I hope that answers your question.
Perfect, thank you. Another question, how early can you identify EOE? And is it possible to have babies in the NICU setting, or is that too early for them to develop this complication?
I can take that one, Beth.
Yeah, I won't touch the NICU.
Again, this is more of a question for a physician, but just from our practice experience at Lurie Children's, we've seen patients as young as 9 months, but we have not seen it any younger than that. That's just in our experience.
Okay, thank you. This next question, how many times do you see both soy and dairy, I'm assuming allergies, due to the cross-link between the two?
You know, I would say in adults, I mean, like, I can't speak to kind of the pediatric experience where, you know, kids can have a colitis that forms because of cow's milk protein allergy. But what I can tell you in our cohort of adult patients, and we're currently analyzing this data further to be able to give some updated numbers on this, but more than 40% of the time, cow's milk protein is a causative allergen food in our EOE patients. And I think somewhere between 15 to 20% of the time, soy and other legumes can be. So I can't speak to how interconnected they are, but just in terms of like what the bigger suspects are, cow's milk protein still outranks soy.
Yeah, and from a pediatric perspective, I agree with Beth. What we found in our elimination diet research is that milk by far was the most causative food, followed by wheat, egg, and then soy. And when I think about that connection between soy and milk protein, I do think to that cow milk protein proctocolitis in the infants, where there is a high likelihood that they may be reactive to both prior to 6 months of age.
Perfect. Thank you for your insights. So we are out of time, so we will wrap up the Q&A session now. I just want to thank everyone for attending today's webinar, and I want to give a special thank you to Bethany and Sally for taking the time to share their expertise with all of us. As a reminder, a copy of the presentation is currently available on the Nutrition Learning Center at nutritionlearningcenter.com, and the recording of today's webinar will be available on nutritionlearningcenter.com within 2 weeks. To claim your CE certificate for today's webinar, please complete the survey, which will appear immediately following the conclusion of today's event. And with that, I want to thank you again for joining us, and we hope you have a great afternoon.
Ladies and gentlemen, this does conclude today's presentation. You may now disconnect your line.